Hi guys, this is the last chapter, chapter 13, Problems and Resilience. Yay, last chapter. You're probably thrilled to not have to look at this ugly mug. So what we need to do here is we need to talk about the two broad problem types that go on during adolescence. One is externalizing problems. Basically, with the externalizing problems, you're looking at risky or problem behaviors. So some examples would be like delinquency, substance use, risky driving, factors involved in risk behaviors, that, like, for instance, drinking under the underage and doing behaviors that may be related to that. This is predominantly, or I should say, is more on the male side. And then you have the internalizing problems, such as like depression, anxiety, eating disorders. With internalizing problems, this is individuals that are over-controlled adolescents. It's more common among the females. The externalizing problems are the under-controlled adolescents, and it's more common among males. A lot of times it's motivated by the externalizing problems is motivated by desire for excitement. Now, we talked about driving. So one of the things we need to talk about is risky automobile driving. Americans ages 16 to 24 have the highest rates of automobile accidents, injuries, and fatalities. Risky behaviors such as speeding, driving under the influence, not wearing a seatbelt. Factors include how the parents are involved, is there parental involvement in their lives, friends' influence, come on, drive faster, personality characteristics, and the concept, ding, 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 of optimistic bias. It's like saying it won't happen to me. I can go 100 miles an hour. Nothing's going to happen. Younger drivers tend to take more risks than the older drivers, with sometimes fatal consequences. So it does happen. Now, it's interesting. The way people get their license now is different than it was when I went for my license. So now you have some preventative measures that have been put into place to kind of help lower the fatalities or car accidents in adolescents. So you have two different approaches here. So you have driver's ed, which generally hasn't worked too well. You get your license faster, you're out there driving and getting into accidents. Now, you guys might have gone through driver's ed at school. If you did, you were lucky, because when I went to school, we didn't have it at school, so we had to pay to have it, and you needed driver's ed to kind of help with their insurance rates. The second is the graduated driver's license, which some of you probably had to go through. So it's more effective. It addresses a variety of risk factors, and it restricts the conditions under which novices can drive. Now, the graduated licensing strategy, there are 3 stages to it. So, 1, you get the learning license, where you get driving experience under supervision of experienced driver. Then 2, the restricted license, where you can drive unsupervised, but with restrictions designed to reduce crashes, like a driving curfew about how many people you're allowed in the vehicle, things like that. And then, of course, the last is getting your full license after a 1-year restricted license. There are other things that we need to talk about when it comes to adolescence and problems and resilience. One of those is substance use. You'll see in your text the statistics on the amount of use or amount of alcohol and drugs that are being used by adolescents. So you have alcohol use, you have cigarette use or vaping use, and illegal drugs such as marijuana, cocaine, LSD, ecstasy. If we were in the classroom, I would have it up on the board, all the different drugs that adolescents are using. I would have listed them based on depressants, where depressant drugs are drugs that decrease your central nervous system. So that means it brings down your heart rate, your breathing, your blood pressure, your temperature. And then stimulant drugs, such as cocaine, for instance, and how that increases your central nervous system. So it increases your heart rate, increases your blood pressure, increases your temperature, and so forth. But again, we're not in the classroom. I don't have a board behind me. So we will not be doing that. But let's look at sequences of substance use. So first, possibly drinking wine and beer. Smoking cigarettes and drinking hard liquor would be next. Smoking marijuana would be the one after, and using harder drugs after that. And there are many reasons, or I should say, substance use varies across Western countries, depending on whether it's legal or cultural differences. In the United States, the higher rates of substance use are among whites and Latinos. Peak use is in emerging adulthood. Due to propensity and opportunity. There is a correlation with unstructured socializing. There has been recent declines in cigarette smoking, binge drinking, marijuana use, and amphetamine use. You'll see in the different figures in your text, figure 13.2, alcohol use among 15-year-olds weekly. Figure 13.3, cigarette smoking among 15-year-olds at least once a week. Figure 13.4, marijuana use among 15-year-olds in the past 30 days. And figure 13.5, substance abuse by age. So make sure you look at those, okay? Now, classifications of substance use, you have experimental, trying it for the first time. Social. Oh, well, my friends are doing it, I'll do it. Medicinal. Self-medicating. You have high rates of depression and anxiety in adolescents, so they may drink or do a drug to self-medicate. And then, of course, addictive or substance dependence, where they actually experience withdrawal symptoms. Withdrawal symptoms could be anything from the shakes with alcohol use, or opioid use, for instance. You see withdrawal such as, sorry to gross you out, but diarrhea, flu-like symptoms, sweats, things like that. It's interesting. I used to work as a detox counselor, so there are drugs that you will withdraw from, some you will not. Alcohol being one that you do, opioids you do, benzodiazepines, barbiturates, all have withdrawal protocol, or detox protocol. So you will see them withdraw. Interesting fact here is the majority of the worst withdrawals are actually with alcohol and benzodiazepines and barbiturates. You can actually die from withdrawal from those. So you need to be titrated down or medicated to not suffer those kind of lethal withdrawal. Opioids, they feel horrible and they feel like they're going to die, but they will not die if they're not medicated. They'll just suffer a lot more if they're not. Anyway, so there are preventative programs within schools. Some of the prevention methods, such as school programs, family functioning, parental monitoring. It's most successful if it's started when they're young. So that is something that needs to be looked at. I know in some parts of the United States, they start as young as kindergarten programs for prevention of substance use. Okay, moving along. Delinquency and crime. Delinquency is when juveniles commit a crime. So there are status offenses where only a violation of law because it's committed by a juvenile, like underage drinking is a perfect example of that. You have index crimes, where are serious crimes at any age, like violent crimes, property crimes, things like that. And then you have the non-index crimes, where they're less serious offenses, such as gambling, disorderly conduct, things like that. There are two types of delinquents. There's the life course persistent delinquents, where you see a pattern of problems from birth on up. They can originate in neuropsychological deficits such as a difficult temperament or learning disability, things like that. These individuals are likely to grow up in a high-risk environment. Now you have the adolescent delimited delinquents, where there's no sign of problems in infancy or childhood. There's a period of occasional criminal activity between the ages of 12 to 25. Some examples would be like illegal drug use, vandalism, things like that. Now, preventing crime and delinquency, there's prevention programs for children who show signs of risk for the life course persistent delinquents and for adolescents engaging in serious delinquency. So varying strategies would be things like individual therapy, group therapy, vocational training, outward bound type programs, scared straight, boot camp type programs. Now, interesting fact, back in the 70s, they did this whole thing about scared straight where they brought the kids that were having problems into the jails and had the prisoners in jail kind of scaring them. Well, the research showed that it didn't work, but we still utilize scared straight programs in some way or another. Two problems with these preventative programs or prevention programs is participants are typically non-voluntary or against one's will, so they're forced into it. Or the prevention comes too late in adolescence after behavior patterns have been established. So this is something that needs to start as quick as possible. So again, we don't always have the ability to start those programs prior. Or right when the first thing happens. Sometimes we think, oh, it was a mistake the first time. Well, maybe if we put something into play, maybe it would benefit these kids faster and they wouldn't have these repeated behaviors. So using a multi-systematic approach where you can direct the energy into socially constructive direction has been seen as more successful or more effective. So it's something that we could utilize and benefit these kids. So, sources of externalizing problems. Going back to externalizing problems. Socialization sources, like for instance, a family structure, family process, parenting style, how a parent parents their kids can help or can show or help in decreasing the amount of externalizing problems these adolescents will have. How their friends influence them. If you're hanging out with kids that are doing these behaviors, you're more likely to do these behaviors. School could be involved. The neighborhood, media, legal system, cultural beliefs, all can tie into these issues with externalizing problems or the lack of issues with externalizing problems. So, some individual factors that can play a part in developing these externalizing problems: gender, ethnicity, aggressiveness, high sensation seeking, cognitive deficits, low impulse control, and again, going back to that term we used earlier in this chapter, optimistic bias. Nothing's going to happen to me. I can do these things whether anybody, I can do these things and no, it's not going to affect me or I'm not going to get in trouble. Now, I talked about earlier internalizing problems and adolescents having high rates of depression and anxiety. Depression is an enduring period of sadness. A depressed mood is an enduring period of sadness without any related symptoms. Depressive syndrome is an addition of symptoms such as frequent crying, feeling guilty, lonely, or worried. Excuse me. Major depressive disorder, on the other hand, is an episode that includes 5 or more symptoms during a 2-week period and it disrupts functioning. These are what we call Axis 1 clinical disorders, like major depressive disorder, bipolar disorder, dysthymia, cyclothymic disorder. All are disorders that usually individuals may need some assistance in dealing with. You'll see your slides in your text or in the PowerPoints that talk about major depressive disorder, for instance. So, depressed mood versus major depressive disorder. Causes of depression. Diathesis stress model states that it could be both genetic and environmental influences. So, diathesis stronger if onset is in childhood or adolescence. Stress caused by family or peer factors can also play a part in developing depression. Rates are substantially higher among females than males. So remember that when you're taking your test, if that question is asked. So treatments for depression and depressive moods and things like that. Antidepressant medications. We utilize different ones like Lexapro, Prozac, things like that. I'm not going to get into every medication. We could sit here for an hour just talking about every single medication for depression. Psychotherapy is another thing. Now, it's been shown that medication along with psychotherapy is the most beneficial to helping in depression. Cognitive behavior therapy is one of the better types of therapy utilized to help with depression. You need to recognize those negative attributions. And when utilizing cognitive behavioral therapy, these individuals are less likely to relapse into depression. So, but like I said, most effective approach is combination of medication and psychotherapy. Depressed moods peak in mid-adolescence. So even the text will tell you, and research has shown that psychotherapy is often the most effective in treating young people's depression also. Now, part of depression could be suicide or thoughts of suicide. So risk factors for suicide is depression, family disruption, substance abuse problems, relationship problems outside the family. And suicide can be a result of series of difficulties over time, so things adding on, everything piling on. Now, risk factors for suicide in adolescence, or I should say, yes, risk factors. So attempts tend to occur as depressive symptoms abate. Ethnic differences, there's higher rates in Native Americans and whites. Gender differences, females are more likely to attempt suicide, but males are more likely to actually kill themselves. Females are usually utilizing forms to kill themselves of non-lethal manners, such as taking pills, things like that. Males are usually more lethal forms, such as hanging themselves, using a gun, things like that. And it's interesting here. I had a friend that committed suicide right before graduating from high school, and it was based on the idea he didn't know what he was going to do with his life. He thought he was going to get a job somewhere where his father worked, and that fell through. And he saw his other friends going off to college, things like that, going into the service, and he couldn't handle it. And it's interesting that a lot of people that are suicidal or are going to commit suicide, usually you see them as happier towards the end because now they've made a plan. They thought about it and made a plan, and they know that's what they're going to do, that they start to kind of all that stuff gets off of them. And you might see these individuals starting to give away their personal belongings, things like that. And that's something when I was younger I didn't recognize. It's also a reason why I went into the field of psychology, I believe, is because I saw my friend and he was happy. He was actually different, but I didn't recognize those signs because I didn't have those skills at the time. So these are things that could be considered signs. Doesn't mean everybody that starts giving things away that they're going to commit suicide, but it could be seen as a sign. Another thing we need to talk about are eating disorders. We have the higher rates of them in females than in males. You have anorexia nervosa, which is intentionally self-starving themselves, and bulimia nervosa, where you see binge eating and purging. There is another one called compulsive overeating. That should be self-explanatory. In these eating disorders, anorexia nervosa can cause brittle hair, unhealthy skin, sensitivity to cold, low blood pressure, lack of menstruation. A lot of times they have a cognitive distortion of their body image. In bulimia, you'll see damage to the teeth, blackness in the teeth. Can be a sign of bulimia nervosa because they are making themselves vomit. Well, the acid from their vomit can decay the inside of the mouth, which then you see darker teeth, things like that. Interesting facts. There are famous people out there. Tracy Gold had an eating disorder. She was in Growing Pains. I don't know if you guys have ever saw that show, but she was an individual in Growing Pains. Karen Carpenter died as a result of her eating disorder. She was the lead singer for the Carpenters. Most of you probably don't even know who that is, but some of you might. So she had an eating disorder also. So a lot of times bulimics, for instance, will maintain their normal weight. So you don't even know that they have it or things are going on. Or know that they even have a problem. Some of the factors that play a part in an eating disorder: cultural roots. When you have a culture that emphasizes slimness, most common in middle to upper socioeconomic classes. They're individuals that are generally susceptible to internalizing problems or internalizing disorders such as substance use. Now, treatments for eating disorders, treatment options such as hospital-based programs for anorexia. It's interesting, we have one of the bigger ones, the Renfree Center in Roxborough, Pennsylvania, is very popular to utilize for hospital-based programs. Family therapy is more effective than individual therapy. Getting the family involved is key here. Drug therapies have been seen as ineffective. And interesting, I was talking about cognitive behavioral therapy earlier in the lecture. Well, it's no more effective than any other therapy when it comes to eating disorders. Success is limited here. Individuals do relapse into their eating disorder a lot of times. It's pretty sad, but true. So let's talk resilience. Protective factors. Most adolescents who grow up in high-risk environments exhibit resilience. Protective factors that promote resilience: higher intelligence, parenting that balances warmth and control. We know that as authoritative parenting style. Having strong religious faith also helps to promote resilience, and having caring adult mentors outside the family can also promote resilience. That's why we have these mentoring programs out there for kids at risk to help them. So it's important that you look at resilience in your chapter to understand. There is some research on resilience. Please look at it because you never know if you're going to be tested on it. Ding, ding, ding. So that is it for this text. I hope everybody got something out of it. I have to say it's an honor that I was able to do this with you guys. I'm sorry that we really didn't have as much contact as we would in a classroom, but I hope everybody's doing well and staying safe. If you have any questions, concerns, feel free to contact me, and good luck in your future endeavors. Please give me a write-up of what you thought of the class. Give me your opinion, because I think students a lot of times don't have as much say in what happens in the college level. So feel free to let me know things that need to change, things that need to be added, things like that, and let me know. And again, you need anything, feel free to contact me. Thank you again, and hopefully you guys continue to do well and stay safe. Take care. Bye-bye.